Okay, let's dive into this. Welcome to this explainer on a topic that is just incredibly complex, but honestly, deeply critical: pediatric renal failure. Today, we're going to unpack exactly what happens when the kidneys, which are literally some of the hardest working organs in a child's body, just stop functioning properly. We are going to explore the sudden, terrifying crises that can happen, the chronic conditions that sneak up over time, and finally, the absolutely incredible medical interventions that offer a genuine cure. So whether you're a student, a caregiver, or just someone who's fascinated by how the human body works, you are definitely in the right place.
Here is a quick roadmap of where we're headed. We'll start with the basics of renal failure, move into sudden crises known as acute kidney injury, explore the progressive decline of chronic kidney disease, and then we'll wrap up by discussing life-saving replacement therapies and the hope of transplantation.
All right, section 1. What is renal failure? Because before we can really grasp what goes wrong, we need to understand the baseline of how things are supposed to work. So meet the microscopic hero of the kidney, the nephron. Think of the kidney not just as a, bean-shaped organ, but as a highly advanced, super delicate filtration plant. Picture those incredibly intricate winding pathways inside it: the Bowman capsule, the glomerulus, and the intricate loops, like the loop of Henle. This whole network is responsible for a massive daily task: excreting waste material, concentrating urine, and perfectly conserving electrolytes. When we talk about renal failure, we are talking about the inability of this specific, beautiful structure to actually do those exact jobs. Now, as we evaluate kidney dysfunction, you'll frequently hear two terms that are honestly pretty easy to confuse, but they represent very different stages of danger. First is azotemia. This is the accumulation of nitrogenous waste in the blood. It's a clear red flag for sure, but in and of itself, it is not immediately life-threatening. Uremia, on the other hand, that is a much more advanced, severe condition. This is when the retention of those nitrogenous products starts producing serious, systemic toxic symptoms that involve other body systems. So the best way to think about it is that azotemia is the warning bell, but uremia is the actual fire spreading through the building. Let's move right into section 2, acute kidney injury, or AKI. Let's look at how this builds into a sudden acute medical emergency. So AKI is when the kidneys suddenly and thankfully often reversibly lose their ability to regulate urine volume and composition. It's an acquired, sudden crisis. The filtration plant basically just unexpectedly breaks down. Why does this happen? Well, in kids, the most common cause is transient renal failure resulting from severe dehydration, which causes hypoperfusion. Hypoperfusion just means the kidneys simply aren't getting enough blood flow to operate. Other big culprits include an obstruction in the urinary tract, acute trauma, complications from cardiac surgery, or exposure to nephrotoxic medications like certain antibiotics or nonsteroidal anti-inflammatory drugs. If a child actually experiences an AKI, the clinical symptoms hit fast. The absolute biggest red flag you have to watch for is oliguria, which is a severe drop in urine output. Because the kid isn't producing urine, all that fluid just backs up, leading to edema or profound fluid overload and retention. They might also get hit with nausea and vomiting. And if the waste products and fluid imbalances get severe enough, you start seeing central nervous system involvement, and that can range anywhere from extreme drowsiness to potentially life-threatening seizures. I want to pause here for a second and really emphasize this exact quote from the clinical literature. Hyperkalemia is the most immediate threat to the life of the child with AKI. See, because the kidneys cannot filter properly, potassium just builds and builds in the blood. And excess potassium is incredibly toxic to the heart. It can trigger fatal cardiac arrhythmias out of nowhere. This specific, rapid complication is exactly why a child with AKI absolutely requires emergency, highly specialized pediatric intensive care unit management. Managing this kind of crisis requires a highly controlled, really meticulous approach in the ICU. Step 1 is simply treating the underlying cause. If the AKI is due to dehydration, we urgently restore fluid volume. Step 2 is fascinating but extremely rigorous, maintaining a strict zero water balance. This means the amount of fluid given to the child absolutely cannot exceed the water their body naturally produces, plus what they lose through breathing and sweating. Basically, if they aren't peeing, they aren't getting extra fluid. Step 3 is eliminating dietary potassium and sodium entirely. We have to do this to prevent that deadly hyperkalemia and keep the edema from worsening. It requires immense vigilance from the whole care team. Okay, shifting gears now to section 3, chronic kidney disease, or CKD. We're moving from sudden emergencies to the total opposite side of the coin. Unlike the sudden, crashing breakdown of AKI, CKD is super insidious. It is literally the slow rusting of the filtration plant. Amazingly, a kid's kidneys can maintain normal chemical and fluid composition until more than 50% of their functional renal capacity is destroyed. CKD is this progressive, quiet deterioration over months or even years, leading to irreversible nephron loss. And in pediatrics, this isn't usually caused by lifestyle factors. It's actually most frequently the result of congenital renal defects or severe recurrent urinary tract infections that cause chronic scarring over time.
Because the kidneys are so good at compensating for so long, the timeline of CKD can be heartbreakingly subtle. Early on, a child might just show a weird loss of normal energy or maybe a very subtle pallor. As the disease slowly progresses, you'll start to see a decreased appetite, especially at breakfast, frequent headaches, and the sallow, muddy appearance to their skin. Eventually, if it goes unchecked, it snowballs into end-stage renal disease. At this point, full-blown uremia sets in, alongside severe growth failure and even bone deformities, simply because the kidneys can no longer manage the body's calcium and phosphorus balances.
Which brings us to Section 4, renal replacement therapies. When a child reaches end-stage renal failure, conservative management just isn't going to cut it anymore. We have to artificially step in and replace the work of the failing organs. So we rely on these technological marvels called dialysis to basically act as an artificial filtration plant. And there are two main approaches. Peritoneal dialysis actually uses the child's own abdominal cavity lining as a filter. It's generally a lot gentler, it can be done at home, often overnight while they sleep, and it allows for fewer dietary restrictions. Because of all that, it is highly preferred for infants and younger kids. Hemodialysis, on the other hand, physically circulates the child's blood outside the body through an artificial kidney machine. Now, it achieves very fast correction of fluid and electrolytes, but it is grueling. It requires clinic visits usually 3 times a week for several hours, super strict diet restrictions, and surgical vascular access. The psychological toll here is just immense. Adolescents in particular often deeply resent the enforced dependence, the massive disruption to their schooling, and just the overall loss of control that hemodialysis imposes on their lives.
Finally, Section 5, the hope of transplantation. Look, dialysis preserves life, absolutely, but it is not a cure. It demands major, exhausting lifestyle alterations. Transplantation is the ultimate goal.
96%. That is the 1-year graft survival rate for living donor kidneys in pediatric patients. I mean, what an incredibly powerful statistic, right? While the journey involves major surgery and lifelong immunosuppression to prevent the body from rejecting the new organ, a successful kidney transplant effectively cures the renal failure. It frees these kids from the exhausting, relentless rigors of dialysis machines. It allows them to finally return to school, to grow properly, and to experience a relatively normal, rehabilitated life. So we arrive at this pretty provocative question. As medical technology continues to rapidly evolve, how will we further protect, treat, and completely restore the delicate filtration plants of our youngest patients? We've seen how a symptom as simple as a subtle loss of energy can map to a massive physiological breakdown. And we've seen how human ingenuity has literally created machines to clean our blood and surgical techniques to replace organs entirely. The future of pediatric nephrology is incredibly bright, but it's going to require continuous learning and immense compassion from all of us. Thank you so much for joining me for this explainer. Keep questioning, keep learning, and I'll catch you on the next one.